So guys, in this video I'll basically be sharing answers and explanation with some basic knowledge to these questions. As I mentioned in my previous video, you need to do a lot of questions, but at the same time, if you have a lot of questions, whether they are recalls or review questions or anything anyway, and you don't have explanations to them, they are not that useful, because the goal is not to memorize answers to questions. The goal is to understand the principles and to gain further knowledge that can actually help you to tackle new questions or trick questions. So we'll just get right to it. I plan to make this in installments depending on how useful you found them. Okay, so this is question number 1. Which of the following is the non-viral component of the hepatitis B vaccine? So the hepatitis B vaccine can be the single component vaccine you take as adult in 3 doses, or it can be a component of the pentavalent vaccine you give to children. Either way, the component of the vaccine is exactly what you test for when you want to know if somebody has the virus or the disease, which is basically the surface antigen. So the surface antigen, if it's present, which says the person has the virus or has the infection, and then you can go ahead to do your 5-panel test and then maybe your viral loads to determine treatment. But then, why is it important that the vaccine has the surface antigen? Because antibodies to the surface antigen is what spells immunity. So if you are able to get a recombinant form of this surface antigen, it both stimulates the production of antibodies, which grants immunity, and another way it grants immunity is by stimulation of memory. The body feels that, oh, I've been infected, even though it hasn't really been infected, and so the body has it in memory, produces some antibodies anyway. And that means that even if there is a proper infection later on, antibodies already present are acting, and the immune response is stronger because the body is not seeing it as a first infection. Question number 2. Constipation is a predictable consequence of which of the following? A balanced diet will not give you constipation, should probably just make you alright. Decreased activity of the external anal sphincter should predictably lead to, say, incontinence. Now, this is interesting. Patients with Ehlers-Danlos syndrome, they have diarrhea, and they have what we call secretory diarrhea. And this secretory diarrhea is very persistent, such that even if the patient does not eat, stops eating completely, the patient will still be having diarrhea. Secretion of mucus and all other GI components will still lead to diarrhea. You see this in patients that have a gastrinoma, okay? All these multiple endocrine neoplasia patients, you see this in them. Stopping chronic use of laxative, okay? Chronic use of laxative is not good, although laxative should cause diarrhea ordinarily. Chronic use of laxative can actually cause constipation, but that is a very terminal effect. However, it is predictable that if you're taking laxative and you stop it, a patient should be constipated. And that is very predictable, and that is also the only reasonable answer here, because taking antibiotics predisposes to diarrhea. It alters the body microflora. It increases your chance of pseudomembranous colitis colonizing the GI and then leading to diarrhea. And interestingly, you still treat the pseudomembranous colitis with antibiotics, metronidazole or vancomycin. So stopping chronic use of laxative. But then just an additional knowledge, people who use laxative chronically suffer what we call melanosis coli. This is a histological diagnosis, okay, where because of the chronic use of some laxative especially, the GI cells, especially in the colon, begin to suffer apoptosis. Now, this apoptosis leads to breakdown of the cell products and then eventually deposition of, it is not melanin that is deposited, but lipofuscin. I hope I get that. Okay, hope that's the spelling. So this is what is deposited in the cells, not melanin, but this is what we call melanosis coli. It is a histological diagnosis, and it shows that somebody has been abusing laxative for a long time. Now, question number 3: irrigation of the seated patient's right ear with warm water should produce which of the following? Okay, so this question is asking about caloric test, or vestibulocular reflex, as some people call it. And there is a memory aid that is generally used. Let me call it cows. Now, it is important to note that this cows actually describes a particular phase of the reflex. The reflex is in two phases. There is a fast nystagmus and there is a slow nystagmus. It is the fast phase, the fast nystagmus, that the cow describes, and this is how it works. When you put warm water or cold water into the ear, the brain senses it as either movement in the opposite or in the ipsilateral ear. If you are putting warm water, there's increased activity or kinetic energy of the fluid in the endolymph, and how the brain sees it that the head is moving towards the right. So the eye will quickly, that's the first initial nystagmus, move towards the right. But then eventually realizing that, oh, nothing really moved, it starts correcting back and slowly moves towards the left, just to correct the nystagmus. So you have a fast nystagmus, you have a slow nystagmus. So if you're putting cold water, the ipsilateral ear you're putting cold water is colder now. So the other ear, contralateral, opposite, is hotter, has more kinetic energy relatively. So the brain feels, oh, this is where the head is moving towards. And the eye, the initial phase of the nystagmus, moves towards the opposite side. That is the CO in the cows. But if it is warm, it moves to the same side. I hope you understand that. It's supposed to be clear. So if we understand that perfectly, then we can answer this question. Warm water in the right ear, you're seeing fast conjugate. So what we're expecting is fast conjugate movement to the right, slow conjugate movement to the left. So we basically just look for that. This one says fast movement to the left, no. No horizontal movement, no. No conjugate horizontal, no. The slow conjugate horizontal movement to the right, no. So this is here, I didn't read it well. Slow conjugate horizontal eye movement to the left. So fast is to the right because it's warm water. Slow movement will now be correction to the left. So that is supposed to be our answer. Okay, that is our answer. Question number 4. Neuronal cell bodies innervating the chromaffin cells of the suprarenal adrenal gland may be found in which of the following location? Okay, it's important to note that the adrenal gland itself, especially the medulla now, where you have the chromaffin cells, actually is like a postganglionic collection of neurons in the sympathetic nervous system. So the preganglionic neurons will synapse directly at the adrenal gland. All preganglionic sympathetic neurons take origin from the lateral horns of the thoracolumbar spinal cord. Okay, so you are looking at that will be option C now, lateral horn of the thoracic spinal cord. Ciliary ganglia will not be it. Dorsal motor nucleus of vagus will not be it. Nucleus ambiguous, no. So that is our answer, and that's pretty straightforward because they are asking you basically where do preganglionic sympathetic fibers originate from. Question number 5. A 20-year-old male patient displays biotemporal hemianopia. Magnetic resonance can reveal a developing a tumor severely compressing the visual pathway. Where is the most likely location? Okay, so the important thing in this question is that a patient has biotemporal hemianopia. Okay, and then what we should notice is, okay, looking at the visual pathway. Forgive my drawing. Okay, so this is how it works. All right, now this is optic chiasma, this is the optic nerve area, and now this is the optic tract. Of course, the optic tract will end at the lateral geniculate body, and from there you are going to have your optic radiation going to the visual cortex. Okay, going to the visual cortex. So this is how it works. To understand this question, I think it's an easy question, but just to help us answer subsequent question, I'll go through the defect you see in each of the lesion. So if there is a lesion, say in the optic nerve, you expect just total blindness, because it means that visual impulse will not get to the visual centers from that eye, so you expect total loss of vision, and that's it. If there's a lesion in the optic chiasma, you expect biotemporal hemianopia, and what they're talking about is they are trying to say this is the main thing that is affected. This decusation here is the main thing affected, and if that's affected, you see that these nasal fibers are observing the temporal visual fields. Okay, the nasal fibers here we observe what? The temporal visual field. The nasal fibers here we observe the temporal visual field. So you have biotemporal hemianopia, semi-loss of vision bitemporally. Okay, now imagine that the lesion is in the optic tract. If it's in the optic tract, you have what we call homonymous hemianopia. Homonymous means on the same side. What it means is that on each side of the eye, the visual loss is happening with fibers on the same side. Let's say if it is the right eye and the left eye we're looking at, if the loss is on the right side of the right eye and on the right side of the left eye, that is homonymous. So look at this now. You see that this is what? This is right, if we're calling this right, and you come here, this is still the right side of what? The left eye. So right side, you say is homonymous hemianopia. I think I should type this down, it might be helpful. So, but the last one would be, what if there's a lesion affecting the optic radiation? If a lesion is affecting the optic radiation, you expect quadrantenopia, that's what we call it, quadrantenopia. But then there can be quadrantenopia with or without macular sparing, depending on the level of the lesion. So I'll just type that out. If it's affecting the nerve, you have a total loss. And then if it's affecting the chiasma, what can cause that is usually things like pituitary tumor or craniopharyngioma. You have biotemporal hemianopia. And then if it's affecting the tract, you have homonymous hemianopia. And then if it's affecting the radiation, you have quadrantenopia, plus or minus macular sparing, depending on the level. Quadrantenopia. Alright, so let's move on to the next question. Okay, I don't think I highlighted the answer to that. So this is the answer, optic chiasma. Okay, so a patient is diagnosed with problems in emptying the gallbladder. On blood check-up, one hormone or peptide that is known to stimulate gallbladder contraction is inappropriately low. Which is the most likely one to cause that? They're asking what causes gallbladder contraction, and I think this is an easy question. I will not waste time on it. And of course, the first answer is the correct answer, cholecystokinin. Estrogen does not do that. Pancreatic polypeptide. Somatostatin inhibits almost everything. So yeah, that's the answer. Now, the primary site of hemopoiesis changes location during development. In the fetus, by 8 months of intrauterine life, the primary site of hemopoiesis is in which of the following location? 8 months. So the way you look at it is you have the first 2 to 3 months. Okay, 2 to 3 months is what we call the mesoblastic phase. Mesoblastic, and that is yolk sac. Blood is produced from the yolk sac around this time. Of course, there is an overlap, but then from the beginning to around 2 to 3 months, this is what you get. So 3 to 6 months, that is the hepatic phase. But it's not just the liver. You actually have the liver and the spleen as sites of production of blood cells, red blood cells, hemopoiesis. From 6 months to birth, and of course onwards, you have the myeloid. That's what you call now, myeloid phase. That is bone marrow. And what you have noticed that in children, almost all the bone marrows, all the bones in the body are involved, but in adults eventually becomes more of the exoskeleton that does it. Okay, so that will be what now? Bone marrow for us. As by 8 months, you're looking at bone marrow. So because from 6 months up, this is like what predominates. Actually, there are overlaps, as I stated before. Which of the following back muscle is innervated by dorsal rami? Okay, this is an interesting question because what they're asking you basically is, do you know the grouping and embryology of the back muscles? And I won't go into so much details, but what you need to know is that the back muscles are divided into 3 groups. You should know that already. Okay, so there's superficial. Okay, then you have the intermediate, and then you have the deep back muscles. Okay, both the superficial and the deep all make up extrinsic back muscles, but the deep is the same thing as well, intrinsic. And this is because they develop in the back. So the muscles that develop in the back are innervated by dorsal rami of the intercostal nerve or spinal nerves. Okay, dorsal rami. Whereas the rest will have different innervation. And the deep muscles mainly is the erector spinae. Erector spinae. That's the deep muscle. So this erector spinae is like collection of 3 muscles, which is longissimus, iliocostalis, and spinalis. Okay, so longissimus, iliocostalis, and spinalis. So of course this will be innervated by what? The dorsal rami. So that makes our answer very obvious as longissimus. So if you know your brachial plexus very well, you can actually tell the innervation of the rest of the muscles listed. Number 9, the medial meniscus is attached to, the medial meniscus is attached to the anterior cruciate ligament is false, posterior cruciate ligament is also false, fibular collateral ligament, that's the lateral collateral ligament, is false, medial collateral ligament is correct, popliteus is also laterally located. Now, this question is important to remember in answering the question what they call the unhappy triad of one man that I don't know how to pronounce his name. So, but it's called unhappy triad. Unhappy triad of I hope I can spell it. Odenegu. I think I'm missing something, but forgive me. Okay. So, but then this is like when you have injury to 3 closely related structures in the knee, which is the medial collateral ligament, which is attached to the medial meniscus, both of them ruptured, because anytime one is injured, there's a great chance that the other one will also be injured because these two are attached. Unlike the lateral collateral ligament that is separated from the capsule by the popliteus tendon. Okay, so you have this, and then when you have this plus a ruptured anterior cruciate ligament, so this one makes up the unhappy triad of Ode-Negu. Forgive me, I really don't know how to pronounce that. So that's that. The pneumotaxic center, question number 10, and the apneic center of the brain are located in which of the following? Now they're asking for the location of the respiratory center, and although the answer to this question is pons, I need us to understand that the respiratory center, the main respiratory center, is actually not in the pons, but it's in the medulla. Okay, so they're like four named, but then you can just group them into two respiratory centers. So in the medulla, you have the dorsal, and the ventral groups, okay, of respiratory neurons, and the main one is the dorsal. So those are the major respiratory centers, and they just take care of your basic rhythm of respiration. The pons center is what will now modulate, okay, and in the pons you have the pneumotaxic, okay, and you have the apneistic. Okay, so it's really important to remember which one is upper and which one is lower, because I don't know, sometimes they just like asking that in postgraduate exam. I wonder why, even students exam, undergraduates. So, but how I remember it is that P is proximal, okay, that's how I remember it. P is proximal, so pneumotaxic is actually proximal, whereas apneistic will be distal. Okay, so once I know one, I should know the other. What that means is that the upper pons contains the pneumotaxic center, the lower pons contains the apneistic center. All right, and the two centers will regulate respiration. But remember, as I said, that the dorsal group of respiratory neurons in the middle are actually the main respiratory center. The question number 11, pudendal nerve supplies the following except labia majora, yes, uterus, no, lower end of the vagina, yes, skin of the penis. So what is important to note here is that the uterus is not a somatic organ, it's visceral. So it will have to get visceral and autonomic innervation, but no somatic innervation. The pudendal nerve is a somatic nerve, and even though the pudendal nerve actually arises from how do you put it now? Yes, from both S1 to S2. Sorry, no one, please. S2, S3, and S4. Okay, even though this is the nerve root 2, 3, 4, and that is also the nerve root of the pelvic splanchnic nerve. The pudendal nerve is somatic, the pelvic splanchnic nerve is visceral / autonomic. That is important to note. All right. Question number 12. Which of the following rotates the hip laterally? Well, this is an interesting question because it's actually easy to remember, but it keeps reoccurring, and sometimes I just keep forgetting it. But there are 7. Some people say 6, but if you say 6, you won't be able to answer this question. There are 7 lateral rotators of the hip, and you should just memorize them, whatever you need to do. So the way I look at it is I look at questions on postgraduates. Okay, so this is me trying to find an unhealthy mnemonic, I'll call it that, to solve this question. So that would be quadratus lumborum. I say quadratus lumborum. Quadratus femoris, quadratus femoris. And then the on are the obturators. Okay, so that because you have both internal and externus. Okay, and then the P will be piriformis. Okay, and then the G will be the gemelli or gemelli. So there's inferior and superior gemelli, and then there's another G which is the gluteus maximus, which is sometimes omitted in some books, so that is why you won't be able to answer this question. So what you see there is these are established lateral rotators. The antagonists will be the gluteus medius and minimus now, and apart from the quadratus femoris, which inserts at the quadratus tubercle in the intertrochanteric now, crest, apart from the quadratus femoris that inserts there, and the gluteus maximus, which has multiple insertions including the iliotibial tract. The rest of them directly or indirectly insert on the greater trochanter. Okay, some on the troncharei fossa, but still at the root of the greater trochanter, and that's important to remember. So that is our answer. The lateral rotator here is gluteus maximus. So even if you didn't know gluteus maximus, from the other options you will be able to tell that. By elimination, that is what should make sense. Now, okay, patellar reflex. This is one of my favorites. The nerve roots of tendon reflexes. I actually made a video with a very funny, is it funny now? Maybe funny or lame mnemonic, but it will help you remember. You will always remember all the nerve roots of the popular tendon reflexes. So, but I will just recap it here just for the purpose of the video. So what I do is 1, 2 buckle my shoe means that S1 and S2 is the nerve root for ankle, that's buckle your shoe, ankle reflex. Then 3, 4 will be L3, L4, knee on the floor. So the assumption is that we want to fight, and for some awkward reason we have to knee down to fight. So 1, 2, buckle your shoe, tighten it up, lace it up. 3, 4, your knees on the floor, that is your knee jerk. Okay, and then 5, 6, that is now C5, C6. Okay, you show your muscle, so it's like you try to flex your elbow to show me your bicep. As you try to flex your elbow to show me your bicep, and you're making a fist, two things will contract. So that is both your biceps, and if you look around the forearm, you also see the brachioradialis contracting. So brachioradialis, there are details to this and some brachioradialis. All right, some of these nerve roots are somatic or sensory, and where some are motor. So you have to just check off the other video to see that. It's a very brief video. And then the 5C's, show your muscle. And then of course C7, C8, that is 7, 8 now. 7, 8, you throw a punch. So you throw a punch. So it's like, okay, now you extend your elbow and you try to punch me. Of course your biceps will have to be used to extend your elbow, and that is your bicep reflex. Biceps. Okay, so if you have this in your head, you should be able to answer most questions. Of course I didn't include the maybe NR reflex S4, S5, S3, S4. So but then this should be enough to handle most of the questions on reflexes. So of course this is our answer. Alright. Question number 14. Cartilages are replaced by endochondral ossification. Which are the following the site of primary ossification? So the first ossification centers in bones generally happen in the middle of the bone. So that is the diaphysis. Okay. And then as the diaphysis goes, secondary ossification centers can appear, and the secondary ossification centers is what you call epiphyseal plates. So it separates the epiphysis obviously from the metaphysis also. So this is actually secondary ossification center, epiphyseal plates. Alright. Fertilization of the ovum takes place in the, I don't think I should spend time on this too, takes place in the ampulla. All right, and then it starts moving down for implantation, to go down for implantation. All right, the ampulla is the widest part of the fallopian tube. Okay. Collagen in tendon. Now, collagen is a very special structural protein. It has a very unique structure. So you have glycine, okay, and then you have other proteins repeating. So this is basically what repeats in collagen. And the triple helix protein, unlike the coiled, endlessly coiled elastin. And there are several types of collagen, more than 10 actually. But then you're required to just remember a few. So even though they are asking as if there is a specific kind of collagen in tendon, there is most times an overlap, but it is good to have just pick some, should I say, predominant ones and keep them in mind. For example, that type 1 collagen is mainly seen in tendon. Okay, so which answers our question. And then if you have this info, then you remember that type 3 collagen is mainly seen in the skin. And then type 4 collagen is basement membrane. Okay, so type 5 fetal tissue. So if I remember correctly, in cartilage is where you see more of type 2. So that's 2 cartilage. Yeah. So I usually don't like this kind of question because, as I said, there's a great overlap between them. But then for this question, we have to just memorize some. So we tend to say, okay, this is the more popular one. 1 tendon, 2 cartilage, 3 skin, okay, and 4 basement membrane, and 5 fetal tissue. But there's an overlap, and there are more types of collagen to remember. All right. Okay, so let me keep this close by here. All right. So this is our answer. Blood supply to the proximal part of the femur. Well, this question is tricky, but at the same time easy, because all the 3 answers available here are correct. The proximal femur is supplied by profunda femoris, yes. Medial circumflex femoral and lateral circumfemoral will supply your hip joint, and they are all branches of the profunda femoris. Okay, so but the more correct answer is the branch from the profunda femoris, which also should give a nutrient artery to the femur. So it's like you have the femoral artery, then you have the profunda femoral artery, this being now the superficial femoral, and then the profunda femoral artery now gives rise to the medial and the lateral circumflex. And the main blood supply to the hip joint will come from this medial circumflex, because the lateral circumflex will find a hard time piercing the very strong Y-shaped ligament of Bigelow now. That is iliofemoral, iliofemoral ligament. So that means that the medial is a major blood supply, but that is to the hip joint. Okay, so but the most correct answer here is branches of the profunda femoris. Which of the following occur in final stage of extension in the knee joint? So basically, this question is trying to test your knowledge of the locking mechanism of the knee joint. When the knee joint gets to its final phase of extension, it basically locks. And how you remember it is, imagine how you lock, how you lock a bottle, and then look at the head of the tibia. But this time you are looking at your leg, the right leg. So you are holding your right tibia, and then you are holding the tibia plateau as if you want to lock a bottle cover. So you are going to do what? Laterally rotate it. That's exactly what you're going to do. That is exactly what happens when the knee is locking. Remember, you're using your right leg, and you are using the head of the tibia, not the femur. So when the knee wants to lock, the tibia rotates laterally, and what that means is that the femur will do the opposite movement, rotates medially, okay, and that causes the locking of the knee. When it is time to unlock, the popliteus will contract, and that will do what? Unlock by doing what? Laterally rotating the femur and medially rotating the tibia. So if you understand that, then we can try looking at the answer. It's likely we will not get an answer because like the options are not complete. But the popliteus contraction of the popliteus is to unlock the knee. Okay, so here's a femoral condyle, no completion. Medial rotation of the leg, no. There should be lateral rotation to lock up. Forward movement of the femur on the tibia, no. There should be backward or medial rotation of the femur. That is what should happen in locking. That is final phase of extension. Slight medial rotation of the knee, no. So the slight medial rotation of the knee is a vague option because we are wondering, the knee, is it the tibia or the femur that is going medially? So I think the answer here is ambiguous, but then of course this question is not properly recalled, and if you understand the basic principle of the locking mechanism I've explained, you should be able to get an answer if you see a proper question. Okay, question number 17, landmark in giving pudendal nerve block. Okay, so the landmark is ischial spine, and this is because it can be palpated both per vagina and per rectum. So, but the more common place you are doing pudendal nerve block is in the female patient, and it's usually palpated per vagina, and then you can block the nerve there. Question 18. A lady was bitten by her dog at the base of the thumb, which became infected and spread to the radial bursa. Which of the following muscle tendon will be involved in the infection? Okay, so what you need to understand here is the arrangement of the radial and the ulnar bursa, and I'll just show you a picture to make it easier. So our answer will be here, but we'll come back to know why that is our answer. So let's just look at the picture here. Okay, so this is a picture of the radial and ulnar bursa. Okay, so this is your radial bursa. So you see that it is very separate from the ulnar bursa, which is the rest of them here. All right, and it contains the long tendon of the flexor pollicis longus, whereas the ulnar bursa contains the tendon of the flexor digitorum profundus going to the median and the medial 4 digits. All right, but then you should know something about the ulnar bursa. I know the question is not about ulnar bursa, but it's important to learn this. You should take a cognizance of this. Okay, so these interruptions here, okay, and this continuation here, such that if there's an infection in the pulp of the finger here, it can spread all the way down to even the crease of the wrist. But if you have an infection here or here or here, they will be limited here because there's no connection. Midway they lose some connection with the ulnar bursa. So this is an important point to note, and will affect how you understand spread of infection. Whereas if it is the radial, the thumb that is infected, it will spread all the way also down to the wrist crease. Alright, so we can go back to our question and you understand better now why this is our answer. Flexor pollicis longus tendon. Okay, could it not supply to the angle of the mandible? Well, this is also best explained with a picture, but then the general thing is to understand that the cutaneous supply of the face is provided by the trigeminal nerve. It's not argued. However, sometimes you get questions like the cutaneous supply of the face is wholly provided by trigeminal nerve. What they are trying to test is this exactly what this question is testing, which is the angle of the mandible is still part of the face and it is not supplied by the trigeminal nerve, so it's supplied by the greater auricular nerve, which is a branch of the cervical plexus. So this is what you have, okay, and basically this is what they mean by angle of the mandible. All right, here. So this is the angle here. All right. So you see that it doesn't have the same yellow color you have there. So this is the angle, and that is supplied by superficial cervical plexus, and the branch supplying specifically is the greater auricular branch. The greater occipital is going posterior, or the occipital lesser or greater. So question number 20. A 23-year-old jockey player, whatever, falls from her horse and complains of headache, backache, and weakness. Then radiological examination will review blood in which of the following spaces if the internal vertebral venous plexus was ruptured. So this question is testing your knowledge of anatomy of the vertebral venous plexus. And although you have internal and external vertebral venous plexus, the difference is in the location. The internal is located within the vertebral column, but it's just in the epidural or extradural space, whereas the external is located outside the vertebral column. So it's like outside the vertebra, lying on the body, and then they are all interconnected as they go up. So that already answers our question as epidural space as the location of the internal vertebral plexus, whereas the external one is located outside the vertebral column. So I don't know if there's a way to draw that with my pen, but let me see. So if this is your forgive that. So if this is the vertebra, okay, so what we're trying to say is that, of course, this is the body. Okay, what we're trying to say is that the external vertebral venous plexus will be here. Okay, it will be outside, whereas the internal vertebral venous plexus will be part of the things that are inside here. Okay, overlying the coverings of the neural tissues, the spinal cord now. Okay, so that's internal vertebral plexus, but they are still in the what? They are still in the epidural space. Okay, so if you aspirate blood while doing lumbar puncture, dark blood, you should know you are getting from the internal or external, but from the vertebral plexus. Okay, so most likely internal. And another thing to remember is the fact that this is also where you get what they call valvulus vein of Baxton. Let's see if I can write that. Valvulus vein of Baxton, whether it's Baxton or Baston, I think it's S. Yeah. So this valvulus vein of Baxton is still the same veins here, and that is what provides a spread route for prostate cancer. So you start having back pain when a patient has metastatic prostate cancer. All right, so we can move on. Question number 21. Neurons located in which area release serotonin as the neurotransmitter? Okay, so this should be quick. Periaqueductal gray matter will release enkephalins, that is your opioids, enkephalins, that's opioids now. Okay, that's naturally occurring opioids. Interneurons of the spinal cord can release both enkephalins. I think some actually release acetylcholine to just enkephalin to moderate pain, acetylcholine for excitation, and any other. They can release a lot of neurotransmitters. Then I think this should be paraventricular area or paraventricular nucleus, which you find in hypothalamus, will be secreting ADH, oxytocin too. Okay. The nucleus Raphael magnus is actually our answer, which will be secreting your serotonin, that is 5-HT. Yeah. And then locus ceruleus will secrete catecholamines. All right. So your adrenaline, no adrenaline, that's what you get there. Okay. So I hope that's clear. Yeah. I think that's clear. Yes. So question number 22, drug that inhibit phosphodiesterase used for treatment of asthma patient has the following effect. So example of phosphodiesterase inhibitor that you can use to treat asthma patients is aminophylline or theophylline, okay? And what they do is they inhibit phosphodiesterase inhibitor. Phosphodiesterase, so what they inhibit phosphodiesterase. And phosphodiesterase enzymes, the enzymes are supposed to degrade cyclic AMP. So if you're inhibiting the phosphodiesterase enzymes, you are increasing the concentration of cyclic AMP, which will in turn lead to phosphorylation of some enzymes and eventually bronchodilation. So you have relaxation of the bronchus via increased cyclic AMP as the mechanism of action of aminophylline or theophylline. Question number 23. Which of the following neurotransmitters are at the end of preganglionic neurons that stimulate the adrenal medulla? So we attended to a question like this, and I mentioned that adrenal medulla is a postganglionic collection of neurons. So the preganglionic neurons in both the sympathetic and parasympathetic nervous system, all of them release acetylcholine. So it is when you come to postganglionic that you start seeing some changes, and the changes will be things like for parasympathetic you still have acetylcholine going, but for sympathetic, apart from say sweat glands where you can have acetylcholine, most places you start getting catecholamine secretion. Okay. 24. A 5-day-old child diagnosed with non-communicating hydrocephalus. Which of the following is most likely to lead to such condition? So there are two types: communicating, non-communicating hydrocephalus broadly. And the way it works is that if the cause of the hydrocephalus, which is basically obstruction to CSF flow, if the cause of the obstruction is within the ventricular system, it is non-communicating. If there's obstruction outside or any other cause of hydrocephalus like excessive secretion, it is communicating. So communicating can still be due to obstruction, but the obstruction is not within the ventricular system. What constitutes the ventricular system? What we consider the ventricular system is you're going from the lateral ventricles, okay? You pass through the interventricular foramen, okay, to get to the third ventricle, all right? And then from the third ventricle, you pass through the aqueduct, cerebral aqueduct of Sivus, to the fourth ventricle. So any blockage here, interventricular foramen of Monro, or here, cerebral aqueduct of Sivus, will give you non-communicating hydrocephalus. Okay, so but then if you start having obstruction to CSF resorption when it has passed into the subarachnoid space through the medial and lateral foramen in the fourth ventricle, that is both Magende and Loschka, from there it has gone into the subarachnoid cistern and then to the subarachnoid space, and then wants to go from through the arachnoid granulation into the dural venous sinuses, and let's say there are obstructions there, you will not call them non-communicating. That is a communicating hydrocephalus. So that is something to note. And then if CSF overproduction is happening, that is also a communicating hydrocephalus. So 5-year-old child that diagnosed with non-communicating hydrocephalus means that the obstruction of CSF, which of the following most likely lead to the condition, will be obstruction of CSF circulation. Excess production, no. Increased size of head does not concern us. Disturbance of reception of neural, failure of neural tube to close also does not concern us in this question. So we stick with this, so but you need to be more detailed on it, and then that's the explanation here. Alright, so finally for part 1 of these questions, which system transmits somatosensory information with the highest degree of temporal and spatial fidelity? Now, this is why I say it's important to do review questions. This question is directly from Guyton Review of Physiology, and the important things they want to take note of is transmission with high degree of temporal and spatial. And what does this mean? It's basically saying that sensory information conveyed mainly by the dorsal column and the anterolateral system, that is dorsal column, medial lemniscal pathway now, and then the spinothalamic tract. But he's saying that the organization, you have to read the book to anyway to know that, or to have been told, the organization and speed is better with the dorsal column generally. So the spatial thing is that the arrangement of the nerve fibers with relation to and the message they are carrying with relation to the part of the body they are coming from is better organized in the dorsal column, and is more rapid the information is transmitted. So that is the meaning of this temporal and spatial fidelity. So the information there is that it is more and better in the dorsal column than the anterolateral system. So it is something that I feel, unless you've been told, you may not take note of just because of the grammar, because if it is asked properly or with general English, like stating that, oh, we are talking about the arrangement of fibers in relation to the body, I think somebody can work that out looking at all those fasciculus, cuneatus and gracilis in the dorsal column and medial lemniscal pathway. So but that is the answer to the question, and that actually forms the end of this part 1. I didn't want the video to be extraordinarily long, but then if it is any helpful, then you can let me know in the comment section. If there are corrections you think I should make, if there are mistakes I've made, wrong answers, you can also just let me know. If you like the video, I think you can give it a thumbs up. If you don't, come on, thumbs up, thumbs down, not thumbs up now, thumbs down for us, so that we know that we should improve. And very importantly, if you think I should do a part 2 and subsequent installments of this video, I think you should let me know in the comment section if it is helpful. So thank you, and good luck in your exam. I hope that everything works out fine for you.